like that. No, they're so like their focus is to like store young, you know, not this preventative model. Great.
Good morning. Good morning, everyone. We'll get started. Excuse me. Our speaker today is Dr. Joshua Yarrow. The topic is testosterone replacement therapy, preclinical and clinical endeavors to improve efficacy and limit side effects. A couple of announcements. Our next grand rounds will be the 29th of February. Our speaker is Dr. Dan Matlock. The topic will be update on shared decision-making research and policy. Another announcement, our next journal club is the 14th of March. Zoom will be the location, and the presenters are Dr. Sarah Tietz and Elizabeth Blumen. Other announcements, following today's grand rounds, you will receive an email with a link to the recording of today's presentation. Also included in the link will be an online evaluation. Please complete that if you don't get a chance to complete the paper evaluation here today, which I'll hand out. And please submit questions into the chat and Q&A boxes anytime during the presentation if you're virtual. To introduce Dr. Joshua Yarrow, he received his bachelor's and master's degree in kinesiology from Arizona State University and his doctoral degree in sports medicine and athletic training with a minor in human nutrition from the University of Florida. Subsequently, he completed postdoctoral training focused on physiology, aging, and sex steroid hormone metabolism at the North Florida, South Georgia Veterans Healthcare System, Geriatrics Research, Education, and Clinical Center, GREC, and in the UF Department of Applied Physiology and Kinesiology. For the past 15 years, Josh has led a successful research program at the NFSG VHS that spanned the preclinical translational clinical spectrum and focused broadly on determining how the endocrine and nervous systems interact to regulate bone and muscle integrity, along with cardiometabolic and prostate health in adulthood. The two primary themes of his research are determining the sex steroid hormone-mediated mechanisms that underlie maintenance of bone, muscle, and adiposity, and the influence of cardiometabolic and prostate health in older adults, and evaluating pharmacologic and activity-based physical therapy interventions to enhance musculoskeletal integrity and promote use-dependent neuromuscular plasticity after spinal cord injury and in the aging population. During this time, he was affiliated with the VA Brain Rehabilitation Research Center. He founded the Preclinical Musculoskeletal Imaging Core Lab, a national resource for imaging of bone, vascular, and soft tissue morphology in rodents and other small lab animals using micro-CT and DEXA technology. And he held a faculty appointment within the Division of Endocrinology, Diabetes, and Metabolism at the UF College of Medicine. For the last 2 years, he has also served as an Associate Chief of Staff Research at NFSG VHS. In his early career, Josh received a VA Rehab R&D Career Development Award and was subsequently awarded the Presidential Early Career Award for Scientists and Engineers under the Obama administration, which is the highest honor bestowed by the U.S. government to early career scientists. Since that time, he has held numerous federal and non-federal grants at the PI, as PI or local site PI, and has received funding from a variety of private foundations and industry partners. Josh has published extensively in high-impact journals on the topics of sex hormone metabolism, osteoporosis, and bone metabolism, strategies to promote musculoskeletal integrity in the aging and SCI populations, and molecular regulation of muscle and bone loss after SCI. Through his career, he has mentored 8 postdoctoral fellows, nearly all of whom received competitively funded fellowships and/or career development awards, along with 30-plus medical graduate and undergraduate research students. He's a fellow of the American College of Sports Medicine and is actively involved in several other professional societies. And in his personal life, he enjoys hiking, staying active with various outdoor sports activities, watching college football, go Gators, and talking science over craft beers. However, he most enjoys spending quality time with his spouse, Rachel, and their 2 children. Welcome, Dr. Josh Yarrow. Thanks so much.
Thanks, Devin. I appreciate the introduction. Thanks, Carrie, for inviting me to talk, and Hillary. I'm going to talk about manipulating androgen metabolism and some of our preclinical and clinical endeavors to in our attempts to improve the efficacy and safety of testosterone replacement therapy. And so this is a real cover of Time magazine from 2014. I have it in my office. I think it's cool because it has this menopause question. Is this a real thing? I think is what they're trying to imply. Meaning, is the reduction in testosterone that occurs with aging, is this a disease? Is it, what is it? And is this real? And so I'll talk a little bit about that. These are our learning objectives. I'm going to skip over that quickly. And my lab objectives broadly are to discern mechanisms underlying sex hormone mediated effects on muscle, bone, and other organs, and to develop strategies to augment muscle mass and bone mineral density. We do so via mechanical loading interventions and also via pharmacologic interventions, which I'll talk about our testosterone interventions today. We apply this to aging and to spinal cord injury and other traumatic populations. So a little background on androgen metabolism. Let's back this up. So testosterone is a hormone that binds to androgen receptors that are present in any tissue that expresses androgen receptors, which is nearly every tissue in the body. So when I talk about effects of testosterone today, I'm going to focus on muscle, bone, a little bit on adiposity, but I'm not going to talk a whole lot about other tissues. This does not imply that testosterone doesn't have effects on those tissues. It certainly does. And this is something that needs to be considered. Testosterone is also a prohormone, though, for two other bioactive sex steroid hormones. One, dihydrotestosterone, and this happens via the conversion of testosterone to DHT via the 5-alpha reductase isozymes. There's 3 different isozymes, and these are expressed in various patterns across the body. And testosterone is also a prohormone for estradiol via actions of the aromatase enzyme. We're going to focus specifically on dihydrotestosterone pathway today, and DHT binds to the same androgen receptor as testosterone, although it does so with about 3 times the potency of testosterone. So it's considered a true androgen, meaning DHT cannot be converted to estrogen or back to testosterone, and it's a very potent androgen. So one thing I think that needs to be understood about testosterone is the free hormone hypothesis. And the hypothesis is that only free or loosely bound sex steroid hormones exert biological action. So this could be testosterone or any other sex steroid hormone. So testosterone circulates in 3 forms. One is bound to SHBG, sex hormone binding globulin. And this is about 50 to 60% of testosterone. This is a really tightly bound protein. And what this protein does is 2 things. One, it extends the half-life of testosterone in the circulation by preventing testosterone from being degraded. But in doing so, it also completely inactivates testosterone. So you have a lot of testosterone circulating right now, if you're a male, and some if you're a female, that is unable to do anything besides just circulate. You have a very small portion of testosterone that's free, meaning it's not bound to anything, and it's active. And then you have another portion of testosterone that's roughly 40 to 50% that's loosely bound to albumin, which is another protein. And these 2 fractions, free and albumin-bound testosterone, represent the bioavailable fraction of testosterone. And what that means is these 2 fractions can cross cell membranes. If associated to albumin, testosterone can dissociate from albumin, and these androgens or other sex steroid hormones that are circulating in this manner can bind their receptors and exert actions. And so I called this the free hormone hypothesis, although it is actually more than a hypothesis because very mechanistic data has now been done in animals, rats, that do not express sex hormone binding globulin naturally. And if you overexpress human SHBG in rats, you get reduced estrogenic action, you get reduced androgenic action. So there's mechanistic data that shows that sex hormone binding globulin truly inactivates testosterone and other sex hormone binding, other sex hormones. So what are the effects of low testosterone that we know of? And so I have 2 MRIs up here. One is a young active individual on the left, and one is an older individual on the right. And this is not to imply that all of these changes are due exclusively to reductions in testosterone, but reductions in testosterone in males can have these effects. And so what you can see is bone loss. So I've highlighted, this is a femur cross-section from MRI, and I've highlighted the femur in red, and you can see a much smaller femur in the older individuals. This is the muscle cross-section in blue, and you can see that in older individuals, there's a much smaller muscle cross-section. There's increased subcutaneous adiposity in the older individual, which is highlighted in green. There's also increased intramuscular adiposity, which I did not highlight, but you can see there in the blue section. And there's a whole host of other effects of low testosterone, including reductions in voluntary activity, reduced libido, psychological changes, anemia, and increased cardiovascular risk associated with low testosterone. This is increased risk for cardiovascular disease, MIs, strokes, cardiovascular death, and all-cause mortality. So I get this question a lot. How do you know that? And so you don't have to trust me. I'm going to flash across about 12 different journal articles here, and there's many, many more than this, but these are in relatively high impact, well-respected endocrinology journals and cardiovascular journals. And if you look at them, what they show is increased cardiovascular mortality risk of 25 to 250% in men with low testosterone. And then if you look at men with low testosterone who have signs or symptoms of hypogonadism, which are quite vague signs and symptoms, this increases to a 5-fold higher cardiovascular mortality risk for men with low T and signs and symptoms of hypogonadism. So a little background, I think it's important to understand the prevalence of low testosterone because there is a thought that this is not necessarily that prevalent of a condition in men. And so there's some cross-sectional data here from a review by Kaufman. And let me familiarize you with this. There's 3 fractions of testosterone that we talked about. The top graph is total testosterone. The middle graph is free testosterone. The bottom graph is bioavailable testosterone, which is free plus albumin-bound testosterone, as we discussed. And on each of those, there's 3 bars. The bar on the left is young individuals. The bar in the middle is middle-aged individuals. And the bar on the right is elderly individuals. And so the big takeaway from this is if you look at total testosterone, there is only a modest reduction cross-sectionally across the age span. However, if you look at free testosterone or bioavailable testosterone, there's a greater than 50% reduction that occurs as individuals age. And so what are our cutoffs for low testosterone? These vary depending upon the lab, but generally less than 300 is considered low for total testosterone. And for bioavailable testosterone, generally less than 70 nanograms per deciliter is considered low. Again, varies by lab though. In the same review, they also looked at the percentage of individuals who have low testosterone. And as you can see from this graph, it increases as the age increases. They used a little bit different cutoff here for total testosterone. They say less than 320, and for free, they say less than 6. But you can see, according to this data, in young individuals, there's almost no men who have low testosterone. If we go to the middle age group, it's maybe 5%. If we go to older individuals, it's 16%. And if we go to our oldest individuals, it's roughly 30%. So the takeaway here is it doesn't seem very prevalent necessarily. It does increase with age, and it depends on how you look at low testosterone. Do you define this as low total testosterone, low free, or low bioavailable? Regardless of how you look at it, low free or low bioavailable is more prevalent than low total testosterone. So that's one set of data. We also looked at this in my lab in a VA clinical trial that we ran, and we enrolled 203 men who were all over the age of 60. They were all veterans. And we looked at the average testosterone total and bioavailable. And the average we saw in our men was about 400, which is right in line with what Kaufman showed in his previous study for individuals over 60. And for bioavailable testosterone, our average was about 107. But if we look at the percentage of men, veterans, who had low testosterone, we actually saw 35% of men over the age of 60 and 72% of the men had low bioavailable testosterone. So these are much higher levels than Kaufman showed cross-sectionally in his review. So why might this be the case? Well, if you go back and you look at that Kaufman review and you look at those early studies where they assessed prevalence of low testosterone, in the studies assessing prevalence of low testosterone, they excluded a large number of men, including men with cardiovascular disease, including men who were obese, including men who are on a variety of medications. And all of these things have impacts on testosterone. And so if we're looking at how prevalent this is in the entire population, we may need to look in a different manner. When looking at bioavailable testosterone, just a little quick background, this is a tough thing to do. Most clinical labs do not look at bioavailable testosterone, do not directly assess it. And the reason is you have to disassociate testosterone from albumin, and you have to get rid of all testosterone that's bound to sex hormone binding globulin. It's a multi-step process. So we've done this in my lab, and we have done it in a lot of different ways. The gold standard is LC-MS, liquid chromatography mass spec. There's COBOS ELISAs, which are clinical standard ELISAs at my VA in Florida. And then there's also commercially available ELISAs. And regardless of how we looked at it, the values were all the same or very similar. And so we really believe this bioavailable testosterone value. There's other ways to look at bioavailable testosterone, though, and the most common way is a prediction equation. And so based off of our direct measurements, we said, let's look at what the prediction equations say, because this is typically what you would see from a lab. And if you look at the two prediction equations that are out there, the Morris equation and the Vermeulen equation, in this cohort of 206 men that we assessed, they overestimated bioavailable testosterone by 100 to 150% versus a direct measurement. So that's problematic. So we went back and said, well, let's create a new regression equation. In our regression, we included total testosterone, age, albumin, sex hormone binding globulin, and BMI as inputs, because we wanted to see what factors might be able to predict bioavailable testosterone. BMI had no effect. We looked at that because it's a proxy for obesity. But these other variables went into our equation. And so we came up with the Conover-Yarrow equation, which more accurately, at least in this population of older veterans, predicts bioavailable testosterone in comparison to these two previous equations. But you could say that our population of 206 men was quite small. So we agree. So what we did is we went to NHANES. If you're not familiar with NHANES, this is a nationally US population representative sampling of all individuals, males, females, across the age span that directly matches every characteristic of the US population, from age, from sex, from health disparities, et cetera. And so we pulled 2,400 individuals from this who had testosterone measurements. And we broke them out by age. So on the left, black bars are young individuals, gray bars are middle-aged individuals, and white bars are older individuals. And so what you can see is the average total testosterone values, again, are right in line with what Vermeulen said, are right in line with what our clinical trial said. But when we looked at the percentage of individuals with low testosterone, we saw 23% of young individuals, young men, had low testosterone, and roughly 35% of middle-aged and older men had low testosterone. So this is a much higher prevalence than what Vermeulen showed in his cross-sectional data. Why? Because we didn't exclude anyone. We assessed everyone regardless of their health status, regardless of their obesity status, regardless of their drugs and medication status, because we were trying to figure out the true prevalence of low testosterone. So the takeaway here, I think, is that maybe low testosterone is a little bit more prevalent than we realize if you don't exclude anyone from these calculations. And so why does this matter? In this same study, we also looked at associations with multimorbidity. So if you're not familiar, multimorbidity is having two or more of the following conditions: type 2 diabetes, cardiovascular disease, which includes congestive heart failure, coronary artery disease, angina, stroke, hypertension, pulmonary disease, arthritis, or clinical depression. And so if you look at this across the age span, there's an increase in multimorbidity, and the gray hashed bars there are the individuals with low testosterone. The black bars are individuals with normal testosterone. And so in all instances, individuals with low testosterone have higher risk for multimorbidity. And if we compare tertiles, meaning the individuals with the lowest testosterone, to the individuals with the highest testosterone, low testosterone tertiles are associated with a 3-fold higher risk for multimorbidity. And the mid-tertile testosterone is associated with a 1.75 higher multimorbidity risk. So not just is low testosterone a thing, but low testosterone is associated with risk for multimorbidity. So I threw a lot of data at you already. So what do I want you to remember? Testosterone is a hormone and a prohormone for DHT and estradiol. Only free and albumin-bound testosterone exert biological actions. In adult men, prevalence of low testosterone is higher than typically reported, and low testosterone increases risk for cardiovascular-related morbidities and mortalities. This doesn't necessarily mean it's causative. It could be correlational, because perhaps having cardiovascular disease may drive low testosterone. We don't know that from the data I've presented, so I do want to be clear about that. So if you believe low testosterone is a problem, then what's the solution? One solution is treating with testosterone replacement therapy. There's lots of ways in which testosterone can be given clinically in the United States. There's different routes of administration, and I'll go through these. One of them is intramuscular testosterone, and there's several different intramuscular testosterone formulations. One is testosterone undecanoate. This is a very long-acting drug. I'll show you the kinetics on the next slide. This is essentially one injection elevates testosterone for about 10 weeks. There are shorter acting testosterone esters, testosterone enanthate, testosterone cypionate. These require injections once every week, up to once every 4 weeks. There's transdermal patches and gels that can be applied to the skin that drive testosterone across the skin. And these are applied daily. These are very short acting. So if you don't apply a patch or don't apply the gel every day, your testosterone would go into the hypogonadal range. There's oral testosterone that you would have to take twice a day. I'll show you the kinetics on this also. And there's newer formulations than this also. But what I want to show you here is that it can be given in lots of ways, and how you give it might actually matter. So these are the kinetics of long-acting testosterone undecanoate. So the red lines here is the top end of the normal testosterone, which is about 865 nanograms per deciliter at the VA. And the bottom red line is 300. That's the bottom end of normal physiologic ranges. And so what I've highlighted in green here is if you give an injection, you can see testosterone goes up to about the high end of the physiologic range, and then gradually over 10 weeks travels back down to the low end of that physiologic range. You give another injection and it's repeated. And so this yellow part here is where you want to be according to the Endocrine Society. And this is a range of about 400 to 700 nanograms per deciliter. And so you can see for most of the time, this drug generally leaves you in the recommended ranges. Sounds good. This is testosterone enanthate, but you could also proxy this for testosterone cypionate because these two short-acting esters are very similar. And so there's lots of ways in which this can be given according to the FDA. You can give anywhere between 50 to 400 milligrams, anywhere between 1 and 4 times per month. So if you gave 100 milligrams per week, what you would see is, again, these same red lines represent what I explained previously, and this yellow zone is where you want to be. If you give 100 milligrams, it drives you into the super physiologic range for a couple days. And then after that, you come back down into the recommended range. If you were to give 200 milligrams every 2 weeks, it's going to drive you super physiologic for about a week, and then you're going to come back down into the normal physiologic range. If you give 300 milligrams every 3 weeks, you're super physiologic for more than a week, and then you gradually come back down. And if you give 400 milligrams every 4 weeks, you are highly super physiologic for greater than a week, pushing 2 weeks, and then you come back into the normal range. But by the end of that time period, you're actually in the hypogonadal range. And so we need to think about what matters in terms of efficacy and safety when prescribing drugs. And so this might matter. And so when I say highly superphysiologic, I do want to point this out. Nearing 1,800 nanograms per deciliter, which is more than twice the high end of the normal physiologic range. So when thinking about how we give drugs, this is something to consider. So what about the transdermal patches? And again, same red lines here, and yellow area is where we want to be. There's patches and there's gels that can be given. So the data I'm going to show you, orange is a testosterone patch, and then green and blue are testosterone gels in a 5 milligram dose or a 10 milligram dose. And so if you look at this, at 1 day of administration, and then again at 30 days of administration, and then again at 90 days of administration, what you'll see is the testosterone patch gets you into the mid-physiologic range by the middle of the day, and then by the end of the day, you're sort of coming back down. And it repeats that pattern at 30 days and 90 days. If you give a low dose of the testosterone gel, it does the same, and it sort of maintains you right in the middle of that physiologic range. And if you give the high dose of the testosterone gel, it sort of gets you up towards the high end of that physiologic range. But the key is it has to be used every single day. Otherwise, you're hypogonadal. And then what about oral testosterone, which I talked about? This needs to be taken twice a day, and there's an AM dose. And if you do that, you sort of get into the physiologic range, but then you come back down. And if you take the PM dose, you again get into that physiologic range and you come back down. So on average, you're only in the physiologic range, maybe 8 to 10 hours a day, and you're hypogonadal more than that. But of note, in this particular study, 25% of the individuals who received oral testosterone never made it into the physiologic range. So again, things to consider. Not only are your patients going to take the medicine, but is the medicine actually doing what it's supposed to do? Get testosterone into the physiologic range. So what to remember from that? How testosterone is given influences the circulating the concentrations of testosterone. And this varies by administration route, meaning intramuscular versus transdermal versus oral, but it also varies by drug formulation, by the dose you administer, by the frequency that you administer this. And so the question that we thought is, if all of these things affect the testosterone concentrations in the circulation, does this influence the efficacy of the drug? So I start with efficacy for a reason, because in 2004, when I was first getting into this field, the Institute on Medicine had a report, and their direct recommendations were the committee recommends short-term efficacy trials to determine if there are benefits of testosterone replacement therapy in older men. And they didn't mention safety. And the reason they didn't mention safety is at this time in 2004, there was not definitive evidence that testosterone had any benefit when prescribed in medical doses. And their stance was, if you can't show us this works, there's no reason to go any further. We're going to pull it from the market. So they said, focus on efficacy, and we'll see what happens. In 2010, the Endocrine Society came out with recommendations on testosterone replacement therapy, and this was the state of the science in 2010. If you took testosterone replacement therapy and they looked at randomized double-blind placebo-controlled trials, on average, you would see an increase in lean body mass, LBM, of about 2.7 kilograms, 5 pounds roughly. And men would see a reduction of about 2 kilograms of fat mass. So essentially, you see no change in body weight. But they also stated in 2010, there are inconsistent changes in muscle strength and physical function from the randomized clinical trials, and there are inconsistent changes in bone mineral density and several other effects that are purported to happen with testosterone. So this is important because we know anabolic androgenic steroids, when used in really, really high doses that are not medically prescribed, bodybuilders, professional athletes, have tremendous effect on muscle and on bone. But what we didn't know at this time is, could we give it in a dose that was appropriate, that was safe, and get these benefits? So we decided to conduct our own meta-analysis because we noticed something interesting in the literature. And if you're not familiar with meta-analysis data, I drew this red line here. We call this the line of no effect. So if a value falls on this red line, it means that the drug you're testing or whatever it is you're testing had no effect. If it falls to the right, it means testosterone had a benefit. If a bar falls to the left of the line, it means the placebo had more benefit than testosterone on whatever outcome you're looking at here. And the outcome we're looking at is lean body mass. So when we took all of these randomized double-blind placebo-controlled studies that had been conducted at the time, there was a 3.4% increase in lean body mass. That's right in line with what the Endocrine Society guidelines said. But we went a little bit further. Before I get into that, what does that really mean? I like to think of things in like real terms. So if you have a 200-pound man and he receives a 3.4% increase in lean body mass, it's about 6.8 pounds of muscle. It's not bad. So I said we went a little bit further. So what I've done here is I've highlighted some studies in yellow and highlighted some other studies in green. The studies in yellow administered transdermal testosterone. The studies in green administered intramuscular testosterone, because our question was, does how you give testosterone impact efficacy? So the thing to look at is there are a few studies here up at the top in yellow that fall on the left side of the line of no effect, meaning the placebo actually had more impact than the drug itself. But if you look at all the studies at the bottom, which are intramuscular, they all fall on the right side, meaning testosterone had more impact. So if we quantify this, what happens? On average, transdermal studies see about a 2% increase in lean body mass. And on average, intramuscular testosterone sees about a 6% increase in lean body mass. So what does that mean in real terms? A man taking transdermal testosterone would expect about 3.5 pounds of muscle. It's not that much. A man taking intramuscular testosterone would expect 11.5 pounds of muscle gain. This is not with exercise. This is a drug effect. That's a pretty profound difference based on how you give a drug. So if you believe that that's true, and that you're actually measuring muscle with DEXA, because DEXA also measures water as lean and organs as lean. So if you believe that that's true, that that's actually muscle, there should be a performance benefit. And so we looked at this in the exact same manner. Again, transdermal at the top in yellow, intermuscular in green. And on average, in all studies, you see about a 5% increase in maximal strength. If we break this down, on average, transdermal sees no improvement in muscle strength. And the reason for that is there are many studies that fall on the left of this line of no effect, meaning placebo had more benefit than testosterone. If you look at the intermuscular effect, you would expect to see about a 10.5% increase in muscle strength. Again, just from a drug effect. That's pretty effective. But not all transdermal studies are the same. And so I've highlighted this study here intentionally because this is a study that was conducted here in Colorado. I had nothing to do with this study, but I know a lot about it because I've talked with Wendy about it, who was on the study team. They gave transdermal testosterone in 2 doses, a low dose and a high dose. And if you look at the low dose of transdermal testosterone, many of the ways they measured strength resulted in effects on the left side of this bar. If you look at the high dose from the same study, there's many more on the right. And so what we could be seeing here is a dose response effect, potentially. We did the same thing with upper body strength. Overall, there was about an 8% increase in strength. When we broke this down by transdermal, there was about 4.5%. And when we broke it down by injection, it's about a 13% increase in strength. So again, intermuscular, in terms of muscle performance, is much better. Same thing, low dose, some effects on the left side, high dose, most of the effects on the right side. So again, maybe within the transdermal, we're seeing a dose response effect, meaning how high you elevate testosterone may matter for efficacy. Yeah. No, that is, we took every measure of strength reported in the literature, even if multiple measures were reported in the same paper. And so they measured strength in a lot of different muscle groups. And so we took them all because we didn't want to cherry pick the data. We wanted to report all data that's out there. So we have preliminary meta-analysis data. This is not a finished meta-analysis, and it's certainly not published, but we looked at bone. And so using the DEXA, same thing, all randomized double-blind placebo-controlled studies that administered testosterone either via transdermal or intermuscular. And when you look at the lumbar spine, there's a much larger increase in lumbar spine bone mineral density with intermuscular. If you look at the hip, same thing. If you look at the femoral neck, same thing. And so the takeaway from this, from our preliminary data, is bone mineral density increases 3 to 4 times more in response to intermuscular versus transdermal testosterone. So what to remember from that? How testosterone is given certainly influences muscle gain. It may influence bone gain. We haven't finished that study yet, so I don't want to be definitive about that. So if that's true, what about safety? Does how you give testosterone influence safety? So sort of the state of the science, there are a lot of warnings on testosterone packaging. I don't know if you've ever read them. I have many, many times. They're constantly being updated. And there's a lot of unknowns. And so there's sort of a few big things that I want to look at. Some of these are true for, the liver, only if you take oral testosterone. It's not prescribed very often. There's some prostate issues that may need to be looked at. And one of the questions that's out there is, does testosterone increase risk for prostate cancer? We'll talk about that. For other, polycythemia, testosterone definitively increases risk for polycythemia. There is no question about this. There's very good evidence on this. What about increased cholesterol? We'll talk about that. But the big question that's been out there is, does testosterone replacement therapy increase cardiovascular risk? Now, remember earlier I said low testosterone produces cardiovascular risk, but there's also some evidence out there that says testosterone replacement may increase cardiovascular risk. So how do we settle this debate? So here's my Time magazine cover again, and about 2014, 2015, the FDA placed a black box warning on testosterone, saying that there is cardiovascular risk associated with testosterone. And there were commercials all over TV, and my endocrinology friends in Florida have told me that a lot of them still now are scared to provide testosterone because they're scared they're going to get sued, because there is a lot of questions out there about the safety of this drug. So if you look at meta-analysis data, I think that this is probably the best way to determine risks if you don't have large-scale randomized double-blind placebo-controlled studies. And so for the prostate, if you look at PSA, prostate-specific antigen, there is increase in PSA that is associated with intramuscular testosterone only. But what is the increase? 0.271 on average. So I'm not a clinician. I'm not going to tell you if that's clinically relevant, but you can make up your own mind. What about prostate volume? Prostate volume also increases. So the question then, if those two things are happening, one of the questions is, does it worsen prostate symptoms? So IPSS, International Prostate Symptom Score, is not worsened, even though the prostate gets bigger. That's good. Prostate cancer. At the time, these were the two biggest meta-analyses that were out there, Cooey and Boyle, and they showed no significant difference between individuals receiving placebo versus testosterone in prostate cancer risk. Moreover, Kaloff estimated that if you were, based off the literature, to want to show that testosterone definitively increases prostate cancer risk, you would need to run a clinical trial involving 85,000 men per arm, meaning 85,000 men receiving testosterone versus 85,000 men receiving placebo. It's never going to happen. It's too expensive, it's too large, but that should show you what, if any, risk there is quite small, because you need study that large, 170,000 people, to show definitively that it would do this. Cholesterol and lipids, if you look at total HDL, LDL, or triglycerides based off the Haddad meta-analysis, there's no increase that was detected. GU did show there's an increase in total cholesterol in men receiving testosterone. How much? I'm sorry, there's a reduction in total cholesterol. How much? 0.16 units. Again, not a clinician, but you can decide for yourself if 0.16 units is clinically significant. The big question, though, I said, is cardiovascular risk associated with testosterone therapy. And the reason for this is largely two retrospective studies that came out in 2013 and 2014, right before the FDA put that black box warning on testosterone. One is the Vigen study that was published in JAMA, conducted here, and one is the Finkel study published in PLOS One. And so these are retrospective analyses of 8,700 individuals and 56,000 individuals roughly. The Vigen study showed 29% higher MACE, major adverse cardiovascular events, in those receiving TRT. The Finkel study showed a 200% higher non-fatal MI risk. But I'm going to show you some other studies that I think are better, and I'll tell you why I think that they're better. Sharma study published in European Heart Journal. This was done at the Kansas City VA. And they looked at 83,000 individuals, so larger than the previous studies. But they did something that the two studies I talked about at the beginning didn't do. They categorized individuals into three groups: men who had a low testosterone and were never treated, men who had low testosterone and were treated, but their testosterone never got back to normal, and men who had low testosterone were treated and their testosterone was normalized. And what they showed is that individuals who had normalized testosterone versus those who were untreated, normalized testosterone had 56% lower mortality risk, 36% lower stroke risk, and 24% lower MI risk. And if you look at that normalized testosterone group versus the group that got testosterone where the values weren't normalized, the normalized testosterone still had lower mortality, lower stroke, and lower MI. So I consider that a better study design, in my opinion. There's also a host of other retrospective studies that are also very, very large in some cases that show lower MACE, lower stroke and TIA, lower myocardial infarction, lower mortality in individuals receiving testosterone replacement therapy. And then one from Oni et al. Also showed normalized testosterone versus untreated had 24% lower mortality risk, and normalized testosterone versus testosterone use, but not normalized, the normalized still had lower mortality risk. So I think that there's more evidence to suggest from a retrospective perspective that testosterone replacement therapy, we can say, at least is not increasing cardiovascular risk. So Zhu et al. Conducted a meta-analysis, which I think is better than retrospective data. And they showed increased cardiovascular risk when all routes of testosterone were combined together. So we looked at this and we talked to some statisticians about this, who know a lot more about stats than I do. And the statisticians told us that this is an inappropriate statistical analysis for low events. So we repeated this with the proper statistical analysis, and we looked at route of administration, as we talked about before. And so all routes, there was no statistical difference in cardiovascular risk in the randomized double-blind placebo-controlled studies for those receiving testosterone. Injection looked like it had lower relative risk. It was not statistically significant. And transdermal looked like it had slightly higher cardiovascular risk. It also was not statistically significant. However, oral testosterone in these studies definitively increased cardiovascular risk. So Osanya et al. Also looked at every meta-analysis published on this. And so they did a meta-analysis of meta-analysis. And so based on this, they estimated that if there is cardiovascular risk, you would need to conduct a study of roughly 18,000 participants per arm to show that testosterone had cardiovascular risk. Again, a study that's never going to be conducted because it's too large. And why is it too large? Testosterone is generic off-label, and so there's not money to be made from this. So what to remember? Major testosterone-related, TRT-related side effects are similar between administration routes, the side effects. TRT does not appreciably increase risk for cardiovascular events or prostate cancer, but to know this for sure, we would need very, very large randomized double-blind placebo-controlled studies. But remember, we're looking at medically prescribed doses. So what I'm talking about here has no impact on supraphysiologic testosterone use. There is very good anecdotal use that very high doses of testosterone have very bad effects on the heart and the prostate. So we're talking about two different things here, not bodybuilder use, not professional athlete use. We're talking about medically prescribed doses. So our question was, if the way you give testosterone can impact efficacy, but it doesn't impact safety, why? That seems strange. So we've talked about routes of administration so far. And so one thing to consider is how much is given in these various routes, because a very simple answer could be you get a little bit more with intramuscular. And so you get a little bit more benefit, but maybe you're not giving so much that it significantly increases or significantly worsens efficacy or safety, sorry. So let's consider how much is actually given in these doses. So if you take a patch, you can give a 2 milligram patch, or you could give a 4 milligram testosterone patch. And the amount of testosterone in these is 14 to 28 milligrams per week. If you give gel, the gel can be given in 50 milligram or 100 milligram doses. So there's more testosterone here, 35 to 70 milligrams per week. And if you give injectable intramuscular testosterone, I said you can give it anywhere from 50 milligrams to 400 milligrams every 1 to 4 weeks. 50 milligrams to 100 milligrams sounds like a dose response effect because that's larger than either of these two things. But one thing that needs to be considered is what's in the weight of that 50 milligram or 100 milligram. It's not all testosterone. Part of it is the ester attached to testosterone, enanthate, cypionate, undecanoate, whatever it might be. So for the case of enanthate, the weight of that enanthate ester is about 28% of that 50 milligram or 100 milligram dose. So if we multiply that testosterone dose by 72, which is the amount of testosterone present, this is the amount, 36 to 72 milligrams of testosterone that's actually present. So the amount in gel given per week and the amount in intramuscular given per week is actually identical. So if that's true, then the dose response effect cannot be true because we're giving the same amount. So to back this up a little bit further, if you believe those mathematical calculations are true, then we should see the same thing when we look at the change in testosterone across clinical trials versus if you give transdermal versus intramuscular. And in fact, we do. So the studies that give transdermal testosterone result in about a 2.5% increase, a 2.5-fold increase in circulating testosterone, and intramuscular injections result in about a 2.9-fold increase in intramuscular testosterone. So very similar increases in circulating testosterone, which you should see based off the mathematical calculations. So what else could be involved then in improved efficacy but not worsened side effects? Androgen metabolism is something we haven't considered yet. So remember, testosterone is a hormone. It's also a pro-hormone. And so the type 1, type 2, and type 3 5-alpha reductase enzymes are present in a whole host of tissues throughout the body, but not all tissues. And so this graphic shows where type 1 5-alpha reductase is present on the left and where type 2 5-alpha reductase is highly prevalent on the right. And so oral testosterone undergoes first-pass metabolism in the liver. Well, the liver highly expresses both type 1 and type 2 5-alpha reductase, which means testosterone has a high likelihood of being converted to its metabolite DHT in the liver. If you give transdermal testosterone, you're applying it to the skin. The skin highly expresses 5-alpha reductase, scalp, chest and back skin, shoulders, all skin. So you would expect higher DHT in transdermal. And intramuscular is given into the muscle. And muscle does not highly express 5-alpha reductase. So perhaps androgen metabolism may be playing a role. So again, if you believe this to be true, we should see changes in DHT that depend upon the way you give testosterone. So we looked at it. This was an article we published in BMC Medicine a number of years back. And the part I'm going to highlight here is elevation of serum DHT varies by route of testosterone administration. And so again, this is just a graphic I took from our article in which we looked at all randomized double-blind placebo-controlled trials and in general that had DHT measurements. And in general, it didn't matter where individuals started. They were roughly about 15 to 20 nanograms per deciliter in DHT. When you give intramuscular in blue, you see a slight increase in DHT. When you give transdermal, you see a 4-fold higher increase in circulating DHT. Remember, transdermal is pushed across the skin. Skin has high 5-alpha reductase. And when you give oral, you see an even higher increase in DHT. And remember, the liver expresses both type 1 and type 2, and so this would be expected. So our data backs up the theoretical argument that I just made. Changes in DHT matter, perhaps. So again, DHT, testosterone undergoes tissue-specific metabolism to DHT. This DHT is 3 times more potent. And so why might this matter? Well, there's a historical perspective on this, and this is a quote. Testosterone activity appears to depend on the formation of DHT. And I took this from the Clinical Pharmacology database in 2017. I do not believe it states this any longer. But at the time it did. This is not my perspective. It is not my lab's perspective, but it is a very historical perspective on the entire field. Up until around this time, individuals believed that the effects of testosterone, the anabolic effects of testosterone, were due to testosterone being converted to DHT. And the reason they believed this is because DHT is 3 times more potent than testosterone. So our lab hypothesis was the 5-alpha reduction of testosterone to DHT mediates androgen-induced prostate enlargement, but that it is not required for the musculoskeletal or the lipolytic effects of testosterone in adult males. And the reason we believe this is because the prostate highly expresses 5-alpha reductase. Muscle and bone do not, and fat does not. So if this hypothesis is true, we wanted to figure out, how do we prove this? So what we did is we went back to some of our animal models. So I run animal studies and I run meta-analyses and I run clinical trials. And so we try to use each of these tools in a unique way to try to come up with answers to questions. So in this animal study, our animal model was the rat, and we used male and female rats, and we gonadectomized them. So a gonadectomy in a male is an orchiectomy, we remove their testes, and in a female, it's an ovarectomy, so we remove their ovaries. And so I want to familiarize you with this slide. So these are histological sections of cancellous bone present at the proximal tibia. And so this purple stain, that's, I don't know if you guys can't see my mouse, can you? No. So the purple stain there at the top is the growth plate at the proximal tibia. And the black stained area below that is cancellous bone. That's what we're going to quantify as cancellous bone. So we have males at the top and we have females at the bottom. And these are shams, so just normal males and normal females. When we gonadectomize them, you can see that there's about a 70% loss of cancellous bone in the males, and there's about a 60% loss of cancellous bone in the females. So there's less black stained area below that purple stain. And if we gave back a supraphysiologic dose of testosterone, in males, we fully protected against the effects of orchiectomy. And in females, we partially protected against the effects of orchiectomy. So I kept the female data on here because this is my only slide on females, because we're not saying that females are not important, first off, the most important. But I think this is evidence here that there are things beyond testosterone that are beneficial to bone in females, estrogen. Although testosterone can be converted to estrogen, giving testosterone does not reproduce the estrogenic levels before ovarectomy. But if we focus on males, this shows that testosterone can prevent bone loss, but it has a side effect. And so that was the first part of our hypothesis. Testosterone can prevent reductions in bone. This is prostate weight, same study. So black is shams, white is orchiectomy. You remove testosterone, the prostate gets a lot smaller. And if you give back testosterone in the dose that we gave it, the prostate gets way bigger, okay? We gave it in this dose intentionally because this is an effect we were trying to drive. We were trying to produce prostate enlargement. It's a doubling of the prostate mass. So why did we want to do that? Because we wanted to try to prove our hypothesis. And our hypothesis results, if this is true, we have to be able to block this 5-alpha reductase enzyme. And so at the time, we used an experimental drug, MK434. And the reason we used this experimental drug, which is a dual 5-alpha reductase inhibitor, is because there was not at the time a clinical 5-alpha reductase inhibitor. There is now dutasteride, but it was not commercially available at the time. And so what this drug does is it completely inhibits the type 1, type 2, and type 3 5-alpha reductase enzyme. So it blocks the ability of testosterone to be converted to DHT. So this is cancellous bone again. And so again, that black stained area at the top underneath the growth plate is what we want to quantify. And this is sham animals. They have about 15% cancellous bone. If we orchiectomize those animals, bone goes down, as I previously showed you. If we give back testosterone, we completely prevent that bone loss, as I previously showed you. If we orchiectomize the animal and give the MK drug, nothing happens because there's no testosterone, so there's nothing to block. And if we give testosterone in a supraphysiologic dose and we give the MK drug, we not only prevent all bone loss, we result in more bone than in sham animals. So first off, how could that happen? Well, testosterone has metabolites. We've blocked its ability to be converted to one of its metabolites, DHT. It can still be converted to its other metabolite, estrogen, and estrogen has profound effects on bone. So by inhibiting one pathway, the other pathway is upregulated. So that shows us that DHT is unnecessary for bone protection. What about prostate? So again, here's our sham animals. We orchiectomize them, the prostate goes way down. We give back testosterone, the prostate mass goes way up. We orchiectomize with an MK drug, nothing happens because there's no testosterone to inhibit. And if we orchiectomize the animals, we give them a supraphysiologic dose of testosterone, and we give the MK drug, we result in prostate mass that's smaller than sham animals. So again, showing that the conversion of testosterone to DHT is what drives prostate mass. And so I said we gave a supraphysiologic dose of testosterone. Let me quantify that. We elevated testosterone 7 times higher than the physiologic range. So even with a dose of testosterone that is 7 times higher than the physiologic range, we shrunk the prostate. This shows you how impactful DHT is on prostate enlargement. So what about muscle? I just circling the last group here, which is the combined group, and we prevented muscle loss to the same degree as testosterone alone. So now we've prevented bone loss, we've prevented muscle loss, and we've shrunk the prostate. So what to remember? In adult male rats, 5-alpha reductase activity mediates androgen-induced prostate enlargement, but it is not required for bone or muscle preservation in the presence of sufficient testosterone. So our next thought was, can we manipulate these findings? Can we utilize these findings to improve testosterone replacement efficacy and safety? So we ran a clinical trial in which we enrolled 60 men who were over the age of 60 who had low total or low bioavailable testosterone. So the 12-month double-blind, placebo-controlled randomized clinical trial, we gave a slightly higher than replacement dose of testosterone, 125 milligrams per week testosterone enanthate. This is not a bodybuilder dose. The highest recommended dose is 100 milligrams per week. We gave 25 milligrams higher than that, in combination with finasteride, 5 milligrams per day. And this is a 2x2 factorial design, meaning there were 4 groups, one group that received testosterone plus finasteride, one group that received testosterone with a placebo, one group that received a placebo with finasteride, and one group that received a double placebo. So in other words, testosterone and finasteride were given in every combination possible with their respective placebos. And so what did we see? On these next few images here, red is going to be the group that received testosterone only. Green is going to be the group that received testosterone with finasteride. So this is circulating testosterone concentrations. And so what you should take away from this is we elevated circulating testosterone similarly in these two groups. And the two groups that didn't get testosterone, their testosterone values didn't change. This is where the difference occurs in our clinical trial. Giving testosterone alone, highly elevated DHT. Giving testosterone with finasteride resulted in lower DHT than baseline. So every effect that happens after this is due to the difference in DHT between these two groups. So what happened with 1 repetition max strength? This is leg press strength, but we looked at 8 different muscle groups. And we saw on average a 10% increase in 1 repetition max strength across all muscle groups that appeared within 3 months and was maintained in response to testosterone. Co-administering finasteride did not reduce this effect. For lean mass, we saw the same increases for both groups receiving testosterone. We looked at lumbar spine bone mineral density, hip bone mineral density. We saw the same improvements in bone mineral density. We looked at fat mass, the same reductions. So what does this mean? It means that DHT, at least converted via the type 2 5-alpha reductase enzyme, is unnecessary for muscle strength benefits, for bone benefits, or for the lipolytic effects of testosterone. What about the prostate? Because this is what really matters. In this study, we intended to drive prostate enlargement because this was a physiology-based study. We needed to do this because we needed to have an effect to block. So the group that received testosterone alone resulted in a 40% increase in prostate volume over 12 months. It's big. The group that received testosterone with finasteride in green not only completely prevented this prostate enlargement, but resulted in a smaller prostate than at baseline. And so one of the other effects of testosterone, as I talked about, is increase in hematocrit. And so both testosterone and testosterone plus finasteride resulted in similar increases in hematocrit. So what does this tell you? The increase in DHT that results from testosterone drives prostate enlargement, because if we block that, we don't get prostate enlargement, we get a smaller prostate. So the take home is what we saw in our animal model, we reproduced in this clinical trial. And so the conversion of testosterone to DHT does not mediate the beneficial muscle and bone effects or the beneficial lipolytic effects of testosterone. And finasteride is able to ablate prostate enlargement, resulting from higher than replacement testosterone. Again, we administered this from a physiology perspective intentionally to drive prostate enlargement. And even in the face of supraphysiologic testosterone, we prevented that prostate enlargement. So just real quick, my last 2 slides is we also now translated this to other populations, one of them being spinal cord injury. And I'm going to click through this because I know I'm late, but the idea here is the blue bar is testosterone, the red bar is placebo. So we elevated testosterone in this group and we saw improvements in hip bone mineral density, femoral neck bone mineral density, distal femur bone mineral density. We saw improvements in muscle strength, improvements in lean mass, reductions in body composition at a variety of different sites we evaluated. And we saw increases in muscle cross-sectional area in these individuals that produced increases in muscle performance. So my final thought here is sex steroid hormone metabolism can be manipulated to improve testosterone efficacy and perhaps to improve safety. And there are no FDA-approved agents that target both skeletal muscle and bone as a means of increasing frailty and reducing fracture risk. This is where I live. This is my bread and butter, what I'm really interested in from an aging perspective and from a spinal cord injury or other traumatic injury perspective. And so these are all of my collaborators. Without them, I would not have been able to do any of this. Happy to take questions.
In the studies that you did with that, did you evaluate the cardiovascular risk? Have any of the adverse effects?
Yeah, great. That's a great question. So the question was, were there any cardiovascular events that happened in our clinical trials? We have never seen a cardiovascular event happen in any of our trials for men receiving testosterone replacement therapy. We had one event in a placebo group. So we're not seeing that. These are small trials, though. Again, remember, you have to have really, really big trials to be able to definitively show these events if they are true. So, but we haven't seen them.
There are 2 questions from Zoom. So first, you showed that testosterone does increase muscle mass significantly, but does muscle function improve proportionately or at different rates?
So that's a great question. The improvements we see in muscle strength tend to happen primarily within the first 3 months and then are maintained thereafter. The increases in lean mass in terms of when they happen, I have to go back and look at my data a little more carefully. That's a great question, though. I would say, if I had to guess, I think that they're happening about the same rate based off of our meta-analysis data, but I'd have to look at our clinical trial data to see if we have tracked body composition that closely.
And then a last clinical question. You showed that testosterone prevents several side effects. In patients with cancer, SARMs are being tested to sort of bypass these complications. Any thought on the use of SARMs also in aging?
Sure. SARMs are selective androgen receptor modulators. These are drugs that are supposed to mimic the effects of testosterone by binding to androgen receptors in somewhat selective ways. I have not seen definitively good efficacy data on SARMs. And so again, I would approach this the same way the Institute on Medicine did. If you can't show me that these work, then why are we administering them? Testosterone we've now shown works. Now we have to work on the safety side of it. Thanks so much. Thanks.